Welcome to the Principles of Performance podcast, where we discuss how to optimize your health, fitness, and performance. Drawing on decades of experience of working as coaches, consultants, and trainers to top performers, athletes, and teens from professional sports to top universities to the U.S. military, Eric DeGatti and Mike Perry discuss topics and strategies of how to perform at your highest level and be your very best. Join us and our friends and colleagues who are leaders in the fitness and performance industry as we investigate and challenge the most popular training, nutrition, lifestyle, and recovery protocols. And away we go. Here we are with episode 30 of the Principles of Performance podcast. I'm your host, Eric DeGatti, along with my buddy and colleague, Mike Perry. Mike, welcome to the show on episode 30.
How you doing, buddy? It's good to see you. How's everything going?
We're doing good. We continue our lucky streak, 30 episodes in. We keep getting awesome guests. I keep plugging away on my wish list, and this woman is certainly on that list. It's Dr. Kathy Dooley. And if you're not familiar with Dr. Dooley, she's a chiropractor by trade who has practice in both midtown Manhattan and then out in Denver and Boulder, Colorado, where she's talking to us from today. She's also an anatomy instructor at two New York City medical schools, which are Albert Einstein College of Medicine and the Weill Cornell Medical College. She's also an adjunct instructor at New York University's College of Dentistry and a visiting professor for St. George's University Medical School in Grenada, West Indies. She's kind of all over the globe when she's out there. And she's also the founder of the Immaculate Dissection. And that's how I came across Kathy and her work. It's an unbelievable course kind of teaching you about anatomy and what it really does and what it looks like in real life. And then she's also a lead instructor for the seminar series NeuroKinetic Therapy and for Somatic Senses Education. She writes for her own website, which is Dr. Dooley noted, and we will put links to all this up on in the show notes. And she's also a former reviewer for the scientific journal Clinical Anatomy. And so we are thrilled to have you as our guest, Dr. Kathy Dooley.
Wow, thank you so much for having me.
Awesome. So you're a chiropractor by trade, and obviously when people think about chiropractors, you know that they think of like cracking backs, right? And so you've obviously kind of transcended that stereotype and created a powerful and unique niche and brand with what you're doing. What are some of the influences that kind of led you on that path and kind of made you this anatomy goddess, so to speak?
Oh, that's very nice and kind of you. I think that when I was a trimester 1 student in chiropractic school, that's when it started to happen that I wanted to be a rehabilitative chiropractor. I was exposed to the amazing Craig Liebenson, who is also a very unorthodox chiropractor in the sense of the stereotypical chiropractor of what we call the flying seven, just cracking joints and moving on. He really looks at things very deeply and analytically, and I was exposed to him very early on. I got so lucky with a club called Motion Palpation Institute in chiropractic school, and they were very big on Dr. Liebenson in his book Rehab of the Spine. And in his book, it's, huge tome, he talks about how important it is to rehabilitate human movement. It's not enough just to adjust. And that I got bit with that bug, and then got bit with the anatomy bug as I was tutoring that class in chiropractic school.
So, I mean, Liebenson is just a guy that I feel like every time that guy speaks, I'm just like, I'm a moron. And this guy knows more than I could ever imagine to. That guy is just on another level. I actually first learned about his work, back in the early days of listening to Gray Cook. And, early on, there were these sort of early adopters of the FMS. And that's where I first heard of his name. But yeah, talk about someone great to learn from. And I'm sure, I'm sure there's several people that think of you in the same fashion. So, which is pretty remarkable. But, a big part of your focus is on human anatomy. And what is the biggest thing that they didn't teach, people in general about the anatomy and what they really should have focused on? Because I feel like there was definitely some things missed.
Oh, I have to admit that I was part of that. I think in the beginning, when I was going through, you have to take a ton of anatomy in chiropractic school, and I wasn't bitten with the anatomy bug initially. I found it to be enormously overwhelming. And I think it's because of the red tape of the way that anatomy is taught. Origin, insertion, innervation, blood supply. And you look at, I remember opening up Netter for the first time. I'll never forget it. It was 2004, January 2004. I had just started chiropractic school. I opened up Frank Netter's Atlas. I think it was, what was that, version 3 or something at that point. And the skull was one of the first things you see. And I was like, I can't learn all that. This is ridiculous. And it's amazing how wrong that is. But it's such an overwhelming topic that I think that it's hard to break it down simply in a very small amount of time. And the curriculum requirements to pass board examinations makes it really, really challenging for a lot of disciplines to be able to provide a very thorough anatomy education. There's always the part 2, whether I teach at med schools, dental schools, physical therapeutics. I've taught so many different types of schools, probably at least 13 or 14 at this point. With each discipline, their hands are tied as far as the amount of anatomy they can integrate that's functional and assessment driven, because they have to pass a board exam in order to be able to even call themselves a chiropractor or a physical therapist or a massage therapist. So their hands are really, really tied. And then I get them later in continuing ed when they're now applying anatomy in an assessment process. And that's when I think I can really teach them anatomy, because they now can receive it in a way that really applies to the patient or to the client.
So where our world is when it comes to fitness, it's been so parts dominated, almost to the extent where, as you're talking, I'm thinking about like how most people are exposed to anatomy, right? They go into a gym and there's literally like a color coded picture of anatomy that's highlighted of this is the muscle part you're working if you use this machine, because of that, the influences of bodybuilding and physical therapy and kind of the history of it. But from a functional anatomy standpoint and how things actually work, where does that approach go wrong?
This is a great question. I think it starts with not enough physics and not enough biomechanics. Like I'll say to my students, hey, what does the tensor fascia lata do? And they say, oh, it flexes the hip and abducts the hip and internally rotates the hip and extends the knee. And I said, okay, when I'm doing this particular action in front of you, which one is it doing first and most? And the entire room, it could be 150 people, it could be 800 people, it could be 10 people. They freeze and can't answer, because we don't apply a lot of the physics concepts, biomechanical concepts to our teaching of functional anatomy. So I'll say, look, due to link tension curve, you can't do all those actions of flexion, abduction, internal rotation, knee extension. You can't do all those things at once. You have to be elongated on other planes, and then you can fire on a plane due to that link tension curve, due to the building of tension. And they're like, oh, I never really thought about it like that. So those charts are actually really incorrect. They're really, I should say, incomplete. They're incomplete because, when you're doing, like, let's say a squat or a deadlift, you are activating the whole system. It's a compound movement. And so to put people into this box of, I'm going to work my hamstrings by doing a deadlift, and I'm going to stretch my hamstrings before I deadlift. I'm like, okay, well, fine. You understand that you do stretch the hamstrings during a deadlift. On the descent, you stretch them at the hip, and on the ascent, you'll stretch them at the knee. And they're like, I never thought of it that way. And I'm like, well, that's because functional anatomy is not the way that we usually educate people when it comes to human movement.
Now, is it because
So,
we put each of these, I'm sorry, Mike, but
go
is
ahead.
it because we put these parts in silos and not appreciate the interrelationships they have with the other parts, and where you have certain muscles like, the abdominals and the hip flexors, where sometimes they work concurrently and they're working together, and other parts they're working against each other. And so it's not as simple as pointing to that and say, all right, I need to stronger that part, right, to do what I do for this activity. So I'm going to do this exercise because it also works that part, right?
Yes, I had a patient yesterday that he's a hot low back patient, right? He's about to get discectomy, and I can't talk him out of it because he's a new patient and he's already scheduled. So here it is. But I had him in all fours, and I had him knees under hips, hands, under shoulders, neck long, chin back, chest wide, ribs down, hips even, the whole spinal cues of neutrality. And I asked him to pick his knees up off the ground, and he could do it without pain. He was very excited. And he goes, what should I be thinking about in this? Should I be tightening my abs? And I go, your abs are they're on. Your abs have to fire a millisecond before you move any limb. So the moment you picked those knees up off the ground, they were firing. It was such a foreign concept to him because bracing to him, like he felt like he had to brace in order to engage. And this is just a big part of the problem. And we, I think that some of we professionals perpetuate that. We're like, make sure your abs are on, or make sure, let's work your lats and glutes. And we use this language, I think, that really doesn't serve the client as much as we think that it does. And it creates a misconception that some of the things that they do in their life aren't working the parts that they are indeed working.
Yeah. When people ask me, what does this work? I just say yes. What does this work? Yes.
An accurate answer. It's the most accurate answer.
I know, right? So I do have a biomechanics question for you, because I've been in this industry a long time, and I came in a very, very different way. I was a sociology major. I learned early on about kind of movement patterns and adopted the sort of the FMS viewpoint, if you will. And then I would say over the last probably 5 to 8 years, there's been this sort of big swing in talking about biomechanics. Now, I think, just like anything, we can go down rabbit holes, right? So, I see a lot of people in the world of physical therapy and chiropractic using the idea of biomechanics, understanding, like you're saying, because if you guys are doing any type of testing and assessments, you guys really need to be able to target things a little bit more thoroughly. And I would actually say the same thing in the world of bodybuilding, because what we're seeing as a trend now in the world of bodybuilding is, well, if you want to hit the lat at this angle and hit this part of the lat, you have to do this movement and this and that. And which is not a bad thing necessarily in the world of bodybuilding when you're looking to gain symmetry and trying to put on size. But I think what happens is people take these two ends of the spectrum. They're not ends of the spectrum, but we've got the bodybuilding viewpoint and a lot of the stuff that's done with, just biomechanics and treatment. And then we have people that are just doing pull-ups and push-ups. And I think what's happening is they're getting really confused, because they're hearing like, well, I should be feeling this, and should I be targeting this part of this muscle? And I feel like in some way, like, biomechanics are really important, but in some ways, like, it's easy to overthink it, because it's like, well, someone's doing a deep squat. Well, what muscles am I working when I'm doing this deep squat? It's like, you're just squatting. Like, as long as it looks good and it flies right and you're healthy, you're getting stronger. I feel like we're doing pretty good. Do you think in a way biomechanics has actually confused a lot of people when it comes to true function?
I think that biomechanics are, you can't really think about biomechanics in a way that is all inclusive in a big way. So if you're trying to look at, and I'm guilty of this, when I have to teach the way that the sternoclavicular joint moves, I have to teach about the biomechanics of how those things move and what moves the joint. And I think biomechanics are really helpful to break down a region when you're trying to explain how a region kind of moves. But biomechanics are not the easiest way to break down a compound movement like a squat. It's just, and you have to factor in a lot of things. You have to factor in a lot of anatomy and how it's different in every person when you do that. So I think that when it comes to the misfires, especially in a clinical setting for me, it's that I was taught that I won't get paid for a cervical problem if I treat the thoracic spine. So part of me is always like, wait a minute, this really, really sucks. I think that we break things down too narrow with biomechanics. And then we also don't do these all-inclusive functional anatomy assessments. I mean, with the exception of you folks, because of course you're FMS and SFMA. And I think that there's big misses in starting local, but then going global, and seeing those two things as extremely valuable and mutually enhancing rather than the same entity.
So I always like to look at the glass half full. And one of the upsides of being old and doing this a really long time is you see everything recirculate. So when I started off in the late 90s, it was just before the functional, quote unquote, functional movement had gotten really big. And I was blessed enough to learn from people like Tom Purvis, who was really big at the time. And I'm grateful for that, having that exposure. And unfortunately, Tom became kind of the whipping boy for the functional crowd, because it went from, no, he's talking about all these biomechanical things and learning things like shunt and spurt and lever arms and moment arms, and learning about, length tension relationships. And that 5 pounds is not 5 pounds, depending on where it is in terms of the relationship and what tension and stressors it's putting on those muscles and joints. And that kind of got pushed to the side, because everybody said, well, that's, we're not bodybuilders. We're going to go, we're going to get Bosu balls and body blades and stability balls, and we're going to be quote unquote functional, and just kind of replaced machines with a bunch of circus tricks. And so where that kind of got off stray. And then that, I think, translated into what we see a lot in rehab. And, balance training is, I'm going to, stand you on an RX pad for 30 seconds and toss a tennis ball at you. Right. And so let's talk about rehab. And first of all, can we really have an isolated injury, to your point before?
I think this is really, I feel like this is highly improbable. Like, I'll give an example. My patient, this is what makes it hard for me to be, I'm not in network as a chiropractor because I'm so frustrated, because if somebody came to me with an elbow injury, I'm expected to treat their elbow and only their elbow and get paid. And so I was just like, I got so tired of this. I was like, I'm not playing this game. I'm not playing the insurance game of assumption that you get injured in one spot and that's where you're injured. I think this is really tough because the body, it's well documented in research that if you are injured, that you will build a you'll build a compensatory strategy around said injury in order to survive and then hopefully eventually thrive. And you will build this stability motor control program around this. And people build poor compensatory strategies to get them through the moment, but it was very useful in that moment, but they won't necessarily let go of that moment. And that poor compensatory strategy doesn't just get isolated to one area. It is like, if you were to hurt your ankle, you don't just get hurt at your ankle. It's going to change, the strategy of how you work around that problem at the ankle throughout your entire system. It can lead from right foot all the way to the opposite arm that moves with it in gait. So it's really hard for me to box in injury. Although I think that the whole start local, go global thing is a big part of my nomenclature. But no, I don't think that we can I think we can have an injurious process in a regionalized place, but you can expect that there's a compensatory strategy built around that for efficiency that was first acute and then becomes a chronic situation that may be more global.
So when it comes to those potential secondary issues and compensations, is that kind of more of a issue of time and compensation, or rather just the mechanism of injury? What do you think?
I think it's a little bit of both. I think the mechanism of injury is so genius. We really poo-poo it a lot in rehab, and I think that progressive people like you and Mike are easier to convince of this. But I think injury is just beautiful. I think Stu McGill calls it the gift of injury, which I love. There's this beautiful mechanism of injury, and some compensation strategies are actually not so pathological to the patient, are they? But I think that the part that I find so fascinating about clinical practice is the fact that the poor compensatory strategies become something that really is bigger. And I think that's what I built my entire career around, is looking at not just compensation strategies, but poor compensation strategies.
And that's the trick, right? What's the fine line between a compensation and a positive adaptation? Right.
Yeah.
And that's where I think a lot of the mistakes get made. And we get a lot of the arrows as being, quote unquote, FMS guys being connected with that and saying, okay, well, we're just looking for problems that aren't there. We're trying to be these corrective exercise kind of people. And it's like, nah, they're not getting the point. And there's certain asymmetries that we actually want. I work with a lot of baseball players. Their asymmetries is maybe what makes them great. The fact that they have greater spiral bone density in their throwing upper arm, their humerus on their throwing arm, that's a positive adaptation and compensation that we don't want to discourage just for the sake of symmetry, for the sake of this doesn't match my chart or scoring criteria. So I think that that's also something that needs to be understood, that we had this wave, kind of talking about the waves in our industry. We had this wave of, okay, corrective exercise. And if I see, Mike talks about in our course, if you see somebody's knee wobble, a quarter inch in, that you're calling the ambulance. Like, we have to understand that there's certain things that are acceptable, and there's certain things that are even desirable when we look at the unique movement qualities and compensations that we may see.
I think that's a beautiful way to put it. And I heard, I think in my CKFMS with Brett Jones and Craig Cook, Gray said the perfect score on FMS is not 21, it's 14. It's trying to get people general symmetry, right? So they don't have an increased tendency towards poor compensation, and that their sport's going to create some asymmetries that make them an elite athlete. I was working with an elite rower yesterday, and he's very, very frustrated. and we were running, some of his screens, like some of the SFMA screens, and we saw this really big disparity that didn't fit his sport. And I brought this to his attention. He was very aware of it. And we started talking about the fact that all of his doctors before me were focusing on this disc herniation that was in his back. That is the most common disc herniation to happen in rowers. It's a T5, T6 bulge because they're always rowing to one direction. But his provocation was actually, I told him, I put him through, the MSR breakout for SFMA, or rotational breakout for those that are new to SFMA. And I showed him that the problem was actually upstream, that he has an adaptation that's poor and that's why he was not being effective as a rower, and also why I think he developed an injurious process around the problem. And he was like, people just kept doing epidurals into the same spot, and I'm like, and he was like, most of my friends have the same imaging. I'm like, that's my point. Like, you can't take an adaptation that's typical for a rower, and think that's the problem. It's not true. They're going to change their spine. They're going to change their rotation because they're always rotating to one direction in the boat. But it's like a golfer trying to switch arms. Like, you're going to ask them to golf the other direction. You're going to provide them with a general symmetry where they're not, going to adapt poorly and compensate. And then you want some type of resiliency in the patient, but you don't want perfect symmetry. I can tell you, as an anatomist, I've dissected 2,700 people bilaterally. None of us are the same, and none of us are generally symmetrical, or have big asymmetries, but we do have, general asymmetries, and that's what we're going for. Is like, we don't need perfect symmetry. And I think that is something my patients, I really tout to them. I'm like, I don't need you to be perfectly symmetrical. I need you to be generally symmetrical. And I don't want you to compensate too poorly to where we could put excessive stresses on parts that don't fit your sport, or don't fit your lifestyle, or don't fit your workouts.
Before you jump in, Mike, I just want to hammer that point home to people who are listening, is that when we talk about symmetry, most of the research shows you need to have symmetry within reason, right? And it's once you get to a certain tipping point. I know Napick did some research, I think it was on hip extension, that once you get about a 10, it's usually, most of the research shows anywhere between 10 to 15% difference one side versus the other. That's when it gets from that kind of hockey stick of a bell curve jumps up, of where that's where we start to see significant issues. That underneath that, it's not really anything to worry about.
And I wish that I wish all coaches, all therapists would really just start to talk about that. Because if I have to talk someone off the ledge of their MRI one more time, I feel like 70% of my career is people getting hurt, going to get imaging, and then coming to me with all these images that has shown in research over and over that the vast majority of humans are going to have L4, L5, L5S1 disc changes because we're bipeds, or that a right-handed athlete's going to develop, particular tendencies towards their right shoulder, and the same thing with meniscus, same thing with ACL. And I feel like most of my job is just talking people off a ledge that's actually not even peer supported anymore. I'm just like, why are we doing this to our patients, our friends, ourselves? Why do we make everything about these weird, static ideas that don't even check out? And so the idea of general symmetry, I think that is a really great thing to promote to patients and clients. And we have to do it as colleagues. We have to start, talking more and more about that. And I think that's what's so great about FMS and SFMA. What Gray and Brett and the rest of the crew, what you folks do is that you're trying to permeate that into culture, into our fitness culture, that we're not looking for things to be perfect. We're just looking for a certain amount of acceptable adaptation.
So, I'm going to go off script a little bit, as I always do, but, we have a lot of new listeners, and we're using the word compensation and we're using the word adaptation, right? And generally speaking, when people hear compensation, they think negative. And when they hear adaptation, they generally think positive, right? So, because you can have an adaptation through a compensation. And I think a lot of people don't understand that, right? Because it really, what it is an adaptation is you're doing something, and because you're doing something over and over again, your body's responding to that load or that stimulus, right? So there's our adaptation, and generally we're looking for for positive adaptations. And I think one of the things people don't think of is a negative adaptation is often viewed as a compensation as well. So I think the language around compensation and adaptation can be a bit confusing for some people, because they hear compensation and they're like, what, you know, a lot of people, you know how it is, like,
Yes,
I'm compensating. Like, am I gonna die? Am I gonna burst into flames because I'm compensating? Because, you know, I think people don't understand the difference. So, and listen, you're a lot smarter than I'll ever be. So can you kind of just talk about the idea of compensation and adaptation in layman's terms for people? Because I think that'll clear up a lot of things for people when it comes to movement and function.
Oh, I love talking about this, because the word compensation to me means strategy. It's just a strategy around a problem. And so, like, for instance, if you were to sprain your ankle, you're going to have to create a compensatory strategy in this acute and subacute situation if you plan to ambulate, if you plan to weight bear, because there's an inflammatory cascade, there's pain, there's heat that is needed to heal a tissue that has a pretty slow healing time compared to some of the other surrounding tissue, right? This is the most sprained ligament of the body. It's in your foot. It's called ATFL, but everybody's had an ankle sprain probably at some point, or at least rolled their ankle. So you're going to develop a compensatory strategy around that that's hopefully this temporarily really effective thing, right? And in some people that have a poor compensatory strategy, what they'll do is a poor adaptation, where they will excessively create joint mobility restrictions around an area long after the healing process has been complete. So the difference between a compensation and a poor compensation is one that no longer serves the patient for proper execution of movement or healing of injury. And so I don't use the word compensation without adding the word poor to it. And I agree with you, Mike. A big part of my practice is telling people, they're like, well, I'm such an idiot, I'm so broken. And I'm like, whoa, wait a minute. You're talking really naughty about somebody that I'm learning to like here. It's really not fair. The compensations of the body are beautiful. Our ability to adapt, to be resilient and change. It's when the compensation doesn't work for us anymore and creates these weird loading patterns that may no longer serve us. That is when the compensation becomes poor, and why we have to intervene and actually rehabilitate and change the situation.
Love it, Eric. There's a clip for you right there, buddy. That was just setting up a beautiful clip for the interweb. So no, thank you for that. So
I already have it timestamped, Perry.
So, you know, going back to talking about sort of isolation and you know, dealing with injuries and talking about sort of the, you know, the global approach and obviously the isolated approach. But when you're considering all of, you know, everything that happens when it comes to movement, all the layers of bone, joints, cartilage, soft tissue, muscles, fascia, can we truly isolate anything when it comes to function, or do we have to start looking at things slightly differently?
Well, I'll tell you, as a gross anatomist, one of my biggest pet peeves is everyone's focus on fascia. It drives me crazy, because I don't know, it takes me like maybe 100 hours to dissect a cadaver patient, right? From head to toe. And when I'm dissecting, the one thing I think about it is how hard it is to create separation. And my job as a prosector for my university is to attempt to create separation, to elucidate structures. But one of the things I appreciate the most and what I'm fascinated with is that it takes me 100 hours of doing nothing else but dissecting to create separation. So why are we attempting to create separation between these parts, as if the nerves and the fascia and the blood and the muscles and the ligaments and the tendons and the bones and skin are these different things? They are supplied with feedback to the same nervous system. If I take an area around your hand, the bones, the tendons, the muscles, the ligaments, the fascia, they're all giving feedback through the same neural system. Your brain has no idea what your skin is relative to your fascia, relative to your bone, right? It only knows input, proprioceptive input, or pain input. It knows sensory input. And I think if your brain won't differentiate body parts, then why do we as clinicians, and trainers and therapists, why do we try to compartmentalize anatomy? As a holistic practitioner, I think that this has gone too specialized. We have our fascia specialist and our nerve specialist. I mean, it happens in medicine, it happens in fitness. Like, I think that my biggest passion in teaching anatomy is teaching people that all the pieces matter. There's not one piece that matters more than the other piece. And so when we're teaching anatomy with Immaculate Dissection, we're trying to get people out of that box of just like, hey, I'm the fascia person or the muscle person or the bone person. Like, no, you are these things move and flow together as a unit, and they're independent, they're independent features. As far as I can dissect it out for you if you want, but it takes me hours and hours and hours to do that, and I don't think it's necessary to do it in a movement strategy perspective. So I don't.
And I will say that your class does a very good job of that. And one of the eye-opening things that I remember as I took my staff when I had my facility to the bodies exhibit in when they had it in Lower Manhattan, and when you actually see what a quad looks like and how it attaches at the hip, and it didn't look like the anatomy flashcards I had in school. And you're trying to figure out, okay, well, where does the rectus femoris end, and then the next one begin, and it's just this web of all these things intertwining that it's really kind of wild and fascinating and elegant. And so next question is, so how much does our individual anthropometry, such as, Mike talks about in our course, like limb and torso lengths and how that can relate to, as an example, in the squat, it's just one movement pattern, but how much does that impact what a muscle does, and how if I'm doing the same bicep curl next to you, we may be getting two totally different things happening because of limb lengths and lever lengths and things like that.
Mm-hmm. Yeah, it gets really, really complicated. This is I think the really tough stuff of analysis and trying to optimize a patient, is who moves first and who moves most, and where does the person have, movement strategy caveats, right? So, like for instance, I have a patient with knee pain that I was seeing yesterday in New York, and she said every time I walk up the stairs, I feel this pain on the medial aspect of my knee, right? And so I had her put her foot on the stair and show me how to do it. And then I asked her to just push her heel backwards and then redo the step. And she's like, why doesn't that hurt? And I said, because you changed everything. Every little piece of pressure changes everything. And so we have to find a way for you to experience your life without hitting extra pain receptors. And some of that, sometimes it's really easy like that. You get the ability to lengthen a lever arm, right? By pushing through her heel more, she was able to push her femur more posteriorly and wasn't able to take the stress across the knee and hit pain receptors. Sometimes it's super easy, and I get lucky. And other times it's more complicated. Like this person has an actual mobility restriction in a joint due to advanced osteoarthritic changes, and me pushing through their heel won't do jack squat for them because now they can't increase the lever arm. I think that the great challenge is trying to meet people where they're at and take them where they're not. And that's our ID motto, right? We're trying to, if you take someone in a squat and you can't get them to descend, that's why, you see people like Gray Cook put something underneath their heels. Like, can they learn can they teach their brain how to do something with a different strategy and increase this lever arm length here, and this, change the way that the motor control happens at this point here. It's a really, really complicated system. But I think that if you simplify it for people into how do you move and how can we make it easier, it's a lot easier than start talking about, I don't like to get super, super, super technical with my patients, which probably surprises most people. They're probably like, oh God, she's an anatomist. She probably, it breaks down every single part. And I'm like, that's not exactly true. Like when it comes to movement, I want it to be simpler. I want it to be load shared. I want everyone to share the load. So I don't talk in lever arms. I don't really talk in, a lot of that stuff. I mostly talk about, can we share the load with multiple parts so there's not as much overload? And I think we don't talk about that enough. And when I say load share to most people, they're just like, what the hell are you talking about? I'm like, well, like, I feel like that is the easiest thing for my patients to understand. They're like, I need you to put as much pressure in your big toe as you do in your pinky toe. So when you're in the squat, can you find this happy place where your body feels really stable? And can you spread the load across something in order to descend? and they'll talk about how magic it feels, how they're able to get away from pain or increase their depth or change the way their eye positioning is, all from these little micro adjustments. And it really comes down to me, the way I educate people through movement is load share.
Hey, everybody, a quick break in the action here. Hope you're enjoying the show, and we appreciate you listening. We're working hard to bring you the highest quality content and best guests every single week. So if you could do us a big favor and go and like and subscribe to the show on whatever platform you get your podcasts on, it would be greatly appreciated. Be sure to listen at the end of the show also to find out where you can find out more information about our courses, as well as a special discount code for all our listeners. Thanks again, and let's get back to the show. So now I have a bunch of questions that I want to talk about, kind of the magical adaptability of our anatomy. And I love, some of Katie Bowman's work talking about how this isn't even exclusive to human beings, and even talking about how dolphins will lose, I forget the name of which fin that they'll actually lose if they're kept in captivity because they don't need it any longer. And these are just anatomical adaptations that we have based on our environment. And that's something that I try to also, in terms of education for clients, to say, okay, well, don't blame your mother, your grandmother for your bunions. There's something called Wolff's Law, and where we lay down more bone in response to certain stressors, and you keep collapsing that foot in or wearing that tight shoe or both. And it's just your body's response to that by laying down extra bone to actually protect you, because you're not smart enough to protect yourself. Right.
I think it's so beautiful. I think that anatomic adaptation, I mean, I'm obsessed with this, obviously, right? Because every cadaver that I see, every patient that I see is different. And I get this really awesome opportunity to see someone posthumously and watch how their life adapted. Right. And I think one of the most fascinating things is that my students ask me, like, how did they die? Like, what was on their death certificate? Well, the same thing as all of us: cardiorespiratory failure. Like, be more interested in what this person lived with and how they adapted their anatomy to it. Like, we're losing certain muscles, right? We're losing plantaris in our lower leg. We're losing palmaris longus in our forearm because we're adapting and no longer need these things. This is really cool stuff. Like, it's going to take us, thousands and thousands of years to no longer need it, but it's absolutely true. What Katie Bowman says is true. She's an incredible biomechanist. And I think that we underestimate the power of our ability to adapt and it not be pathological. Like, when I see a bunion, it's only pathological if it bothers my patient. It's like that is a supination strategy for a pronation problem. Your body cannot, properly move it through space. It's not because your mom handed you bad genes. And it's not a problem until it's a problem. And that gets back to what Mike was talking about with compensation versus poor compensation.
So I have another tricky question off of that. How much is governed of that by the nervous system, and how much is attributable to load and stress?
I think that we don't really know the true answers to that yet. I don't think that we need to think of those as separate entities. Okay. So if I proprioceptively have a program that encourages me to move a certain way, then I'm going to probably load a certain way. So proprioception does guide our ability to load, to move, to stabilize. And then we have reactive forces from the way that we move and stabilize. So our nervous system is going to change based upon that load or that placement. So I think it's a constantly learning system. And I don't like to think of things as two bookmarked, as one causes the other. And I think it's a lot more mutually enhancing than we like to give it credit for.
Now, I have one more before I pass it back to you, Mike. So there's certain things, and I try to explain to clients, there's certain adaptations or changes that happen, maybe it's through injury or so forth, that they'll go back. Your bone will grow back. It'll sometimes grow back stronger, right? In response to that. And then there's certain things like the ligamentous system, right? That once you stretch or strain that ligament, and now it's got that plastic of property. I explained to him, it's like kind of, you pop, the best way I learned it is like you pop that can out of the 6-pack, it's never going back in snug again. And so now the only thing that's going to hold that joint together is muscular support. So you now just increasing much greater demand for stability and motor control around that joint. And so we're not going to fix that by stretching, because stretching may actually make you worse. So kind of talk about the parts that can come back just as good as they were before, and the parts that don't come back.
Well, that's highly dependent on blood. And this is why I don't pick favorites in anatomy. Okay. But if I was forced to pick a favorite, it would be blood. And it gets so little credit. So the bone has this enormous ability to be able to regenerate, to heal fracture. A huge part of that is because of its capacity to hold blood. And ligaments and tendons are, ligaments less so than tendons are highly avascular. So you're asking something that's not given a really good access to the immune system, to healing elements. You're asking, it has access to innervation, but it doesn't have access to blood. So a ligament is not going to be able to be as resilient. And I agree with you with what you said about the dynamism of tissue has to improve when something else has been hit. And ligaments are a tough one because, they have poor blood supply, so they heal really slowly. But I think that if you have a tendency to have quite a bit of blood and blood around you, then your capacity to heal is going to increase because of your access to the lymphatic and immune systems. So there you are.
That's why they say movement is medicine, right?
Yes.
So
Ocean is lotion.
That's it. So let's over the last, I would say, decade, breathing has been a hot topic, right? And it started with doing a little bit of diaphragmatic breathing, and then PRI came in and made some pretty big impacts on the industry. But let's talk about breathing in general. And can you give us some insight on how our individual anatomy is going to impact breathing in general?
I guess I'm pretty excited to be alive at this time when breathing is making a comeback. Kind of like Eric said things like they wax and wane. If you're in practice long enough, you see things come into style, and breathing is in style. I remember watching this video, like an infomercial when I was a kid, about this woman who was doing breathing. Do you guys remember this? If you Google like 80s commercial breathing lady, she was doing this breathing. Everyone thought she was crazy, and then like maybe so, but now it's in fashion again 40 years later. I think that the root of the majority of what we do to stay alive is breathing. So it makes total sense that life and death begins and ends with breath. So it seems like a crazy thing not to focus on. And then when you get back to the anatomy of breathing and the fact that building intra-abdominal pressure is a huge safety net for our center of mass, and that your ability to be able to do proper gas exchange certainly does change your endurance, athletic output, even anaerobic output, even though it's not dependent upon oxygen for delivery, it is for the movement of lactic acid out of the blood. So I think that the breathing focus, as someone who teaches breathing courses, it's a big deal. But I also think that I really like what it does for people outside of human movement. I think that we underestimate how much poorly adapted emotional, physical job stress affects our ability to move the muscles. Like if you look at Leon Chateau's chart on anxiety, right? And the fact that anxious people tend to overbreathe. People that overbreathe blow off too much CO2. They become a little bit acidotic. So your body will excrete extra calcium, right? When you excrete extra calcium through the kidneys, you end up with sensory disturbances, tiredness, muscle cramping, muscles can't recover as well. So if you're not properly focusing on your breathing, it absolutely does affect your training. If not directly, then indirectly through the overbreathing cycle. And then it becomes a systemic problem. Breathing is a systemic problem. And then it also is something that we use for biomechanics to improve our output. So I think if you don't focus on breathing in someone's training, it becomes a really big problem, especially if their life is more anxious than they like to admit. And a lot of my patients don't even know they have anxiety. I'll watch them breathe and their respiration rate is like 18 to 20 or something. And I'm like, okay, if the average is 12, that's a little high. And then maybe the reason why you hurt, maybe the reasons why you can't recover from your workouts is because you haven't focused enough on your breathing.
So to connect the worlds, something we talk about when we talk about shoulder mobility, and I explain, the impact of breathing on that and how it could affect shoulders. I especially work with baseball players, a lot of shoulder stuff. And then I explain to them the impact of breathing, and I'll have people take a deep breath and kind of feel their belly move and feel the diaphragm if you're doing it right. And then I say, okay, put your fingertips and kind of wrap them around your clavicles, and then take a stress breath, like a bear just walked in the room. And you take that mouth stress breath, and you feel those muscles just kind of grab a stranglehold of your fingertips. And then those are your scalenes, those are accessory respiratory muscles, and those kind of help pull up on your aponeurosis of your lungs when you need to stress breathe, which is good if there's a bear in the room, but there's not a bear in the room right now. And you're doing that, to your point, 18 times a minute times 60 minutes in an hour times, 15,000 times a day. Now imagine if you did that to any muscle, do 15,000 bicep curls, what's your bicep going to feel like at the end of the day? Now that's going to pull your head forward more, which is going to close down the airway more, which is going to lead to more rapid, short, shallow breathing. And now all of a sudden you can't lift your arm overhead without pain. All the stretching, foam rolling, manipulation in the world is not going to make that go away unless we change your breathing, right?
Boom goes the dynamite. You gave I mean, if you were working with anyone that uses their arms in any kind of sport, you don't mess with the scalenes. The scalenes attached to the first rib. The first rib is part of the sternoclavicular joint. Sternoclavicular joint is the one attachment, the bony attachment your entire upper extremity has to the middle of you, the axial skeleton. The last thing you want to do is be breathing there and create tightness around something you're trying to get mobile. This is like this. It's crazy not to focus on breathing, in my opinion, with any kind of athlete, especially any kind of person that uses their arms.
So go ahead, Mike. I know you were trying to jump in with something there.
No, I was just, I was just kind of thinking again that sort of the trends on basic breathing, and I love the fact that it's being incorporated. But I just like any type of new thing, we have people that they go down the rabbit hole and they feel like, okay, like, and I've heard stories of like personal trainers that, from a scope of practice standpoint, they shouldn't be telling people certain things, but you have dysfunctional breathing and you have this, they're diagnosing things because people have, some compromised breathing. And I think, like anything, we need to know our role and know when things are important. But if it's kind of like one of those things, it's if we only tell people what they're doing wrong or what's broken, they're just, all they're going to do is they're going to focus on that. And because they're focusing on this one thing, they're missing so many other things. And I think, just like anything, there needs to be a time and a place to have that conversation, and to do it in a way and to deliver the message that, hey, listen, like this can be changed. This can, this is not a big deal. And I just think we got to stop telling people that they're fragile and they're broken. We talk about this in our course all the time, Eric, but I feel like the whole breathing thing, it's like, you have dysfunctional breathing. Well, yeah, I mean, there is dysfunctional breathing, but telling someone that they have dysfunctional breathing, but not knowing a damn thing to do about it, it's just dumb. And we're not doing anything good for our patients when we do this.
I agree with you. And I am probably obviously a very big cheerleader to my patients, my clients, my students. The feedback that I typically get is that I didn't know I was going to laugh so much at the appointment, or I didn't know I was going to have so much fun. And I think that we forget to make things fun. And like kids, who's more adaptable than a kid? Okay. Who's more adaptable than a child? They're adaptable and they're resilient and they're building adaptation and resiliency. So make it okay to be a little dysfunctional, BFD. You're a little, okay, fine. Not every breath I take is perfect either, but let's see what we can do to see how much better you can get at something, and make it just another skill like anything else. How good can you get it? And like, I make it competitive. I'm like, inhale for 5, exhale for 10. See if you can get it to 6 to 12. See if you can get it to 7 to 14. Don't talk about dysfunction. Get competitive. People are naturally competitive. It's a hardwire in our brain, is evolutionary hardwire. Like, just have some fun and make as many as you can come from the lateral part of your rib cage. Let's have some fun with this, rather than and I'm with you, Mike. I loathe the fragility that we like to. That's a terrible business model, folks. Like, all it is going to make people feel like crap. And then the kind of clients you're going to get are also going to be the ones that are in the doldrums, and they may not be able to be very easily pulled out of it, because people have just been perpetuating over and over what these people cannot do. And the medical community can be really bad at that too. Like, my patient yesterday was told not to lift weights anymore after his back injury. And I'm just like, you're going to lift in life, man. You're going to pick up your laundry basket. You're going to lift up your groceries. Lifting things is going to be a part of life. Let's find a way for you to do it safely in a way that doesn't hurt you. Like, let's have some fun with this. And people are not fragile just because they may be temporarily vulnerable. And I really think that people need to empower their clients and patients. Let's see how much you can do. What can you see yourself do? Instead of this perpetuation of dysfunctional fragility.
I love it. And I love the fact you brought up the word resiliency. And Mike, you're talking about being in our lane. And I think one of the things I was fortunate to learn early on as well is I did 2 levels of Paul Chek's internship, a million years ago when he was first kind of coming to popularity. And one of the things that he said is our job is to be the Robin Hood for orthopedic surgeons. And my job is to keep them out of your office, quite frankly, Kathy. And in order to do that, it's building resiliency. And so I have a couple questions with that. One of the things you talked about was blood supply. And so I'm thinking automatically, all right, if I can get someone more aerobically fit, that rising tide is going to kind of raise, make all boats rise as well. So tell me about where you see less people getting injured, or at least recovering more quickly because of that level of fitness.
Oh, I think that, being a former owner of a kettlebell gym, nobody got a pass. Everybody had to do some type of aerobic conditioning, right? So our programs were built to where people would lift weights based upon an FMS score, right? And then at the end, they would have to do some type of strength conditioning, some type of metabolic conditioning. I think it is crucial. I know I don't have to convince athletes to do it, obviously, but for a lot of my weekend warriors, like if I ask them to do cardio, it's like wah wah wah. I think that you can really help expedite the recovery of muscle tissue by including aerobic activity. It's right there in the research. It's undeniable. And I think that we should never underestimate the fact that aerobic activity is really making the cardiovascular system work. It's moving blood, it's decreasing stasis, it's improving our ability to oxygenate tissue. And it doesn't have to be that long, and it can be intense or it can be moderate. And there's so many fun. It's a way to really have fun with cardiovascular fitness. From a very personal place, I'm concerned about this for myself because my father died of myocardial infarction during the pandemic. And I was always very worried about his cardiovascular fitness. I saw how it went down so much after his first heart attack. And you just don't want to mess with your ticker. You need to move your blood. And on that vein of caring for the blood, it's not just aerobic activity, but improving the quality of what's floating around in your blood, having those hard conversations of if you're not comfortable looking at the blood work, getting someone that really looks at the blood work. And that's a big part of my clinical practice, is looking at people's blood work and asking them questions about it, asking them to get certain tests run, because we need to make sure that you are doing adequately for yourself in a systemic way to enhance your recovery. If you're not doing that, then you really have to wonder, like, systemically how fit you are, even if you are working out.
So another question's popping in my head as you're talking. And as guys who now have a course that we teach program design, I think something that's completely misunderstood, underappreciated, and is the quality of tissue tolerance, right? And so from the beginning of someone working out, getting up off the couch, to understand they can't just go jump into a CrossFit or Orange Theory class and do what everybody else is doing who's been there 6 months. And then also the on the other end of the spectrum of like the magic of tissue tolerance, if you've built up enough for it. When we talk about I deal with baseball, they talk about overuse injuries. I say, well, that's usually more of an under preparation thing than it is an overuse, that you can prepare your body to do a whole lot of magical things. I mean, I just finished David Goggins' book. The guy ran 240 miles on a torn ACL and a tendon that was about to rupture. So kind of talk a little bit about tissue tolerance and how we appreciate that, because I want to hear it from an anatomist point of view who's seen it from the inside out, literally.
Yeah, I think that people always ask me, like, when you're dissecting the cadaver patient, would you be able to predict if the person had something like poor tissue tolerance, or would you be able to see a muscle rupture, or would you be able to see grade 2 strain, versus a grade 1? And gross anatomically, the answer is no. I think we are vastly incredible healing beings. I think that even in my work as a clinician, I have to remind my patients constantly at how amazingly adaptive their bodies are. But I think they have to make smart choices, like the ease in. Adaptation happens because your body is given little tiny bits of something that they can adapt to. You guys folks have, hopefully your listeners have seen the movie Princess Bride, where he poisons the guy because he gives something all at once, but he himself takes it over time and he develops adaptation, right? I think that's the beauty of improving tissue tolerance is this, improving somebody over time. If Mike's trying to train somebody to do a get up, he doesn't hand him a beast, he doesn't hand him a 48 right away. He puts them through the motions of how to do it accurately with load share, and then he progressively loads it. I think that the progressions are something I use a lot in my clinical practice with the patient, that language of progression A, B, C, D. Like, let's start you off with progression A. Then we're going to add in B if you have good tissue tolerance, good adaptation to it, good resiliency. Then we'll move on to C and D, and building, fitness programs and rehab programs around that idea is really, really highly valuable. But I can tell you from an anatomic standpoint on the cadaver patient, like I recently was dissecting this gorgeous cadaver patient. He was 77 years old and more mesomorphic and had more very clean muscle tissue than bodies that I've dissected in their 40s. And I was like, what did this guy do? Like, what did he do so right? Right. And we found out that he died of blunt trauma. He was most likely, hit by a car or something like that, like blunt force trauma. But, that's that's an example of poor adaptation, like your inability to be able to resist this all at once. But he had spent a whole life of having really, really good tissue tolerance. Like, and I don't know what he was doing, but I know whatever killed him was all at once. And we have to be really careful about overloading our system when it hasn't had an opportunity to adapt.
Fascinating stuff, as everything has been that we've covered in the last hour or so, and I can't believe it's already gone by. So before we wrap up, Mike, any final thoughts you want to jump in with?
No, I just wish I could pick her brain for like the next I don't know, couple of years, and I'd probably learn a lot more. But no, Doc, thank you so much for sharing, and thank you so much for your guidance, and just it was such an awesome conversation.
Well, you're both such a memorable thing to me, Eric. For you, I think I went to your gym to take one of my initial courses with NKT, and for Mike, I can never forget what you did for me at Strong First. You probably don't even remember, but I almost flunked my Strong First 2 exam, but Mike took me to the side and helped me with my windmill. And I think you're just both incredible people and incredible at what you do. And I hope your listeners fully appreciate what you bring to the table as far as, progressive thoughts in our field.
Greatly appreciate it. And Mike Perry, once again, to the rescue. You're like a superhero. Perry.
No, usually I'm usually the one going, help.
He's very humble, very humble guy.
So before we wrap up, I want to know, Kathy, what do you have coming up in 2023? What are some exciting projects you're working on?
Oh, wow. Next week I fly to Istanbul, Turkey. It's my first time teaching there. I'm pretty excited about that. I'm teaching my temporomandibular joint course and NKT over there. And I'm flying to various places to teach, which I'm pretty excited about. And of course, I'm very excited to do some prosection coming up at the medical school and dive even more into the cadaver patient so I can share knowledge with anyone who will listen. And so that my husband doesn't have to hear all of it. And I'm super excited just to be a great clinician and to teach these amazing courses. If you folks want to check out some of the courses that we have to offer, I'm sure that you'll provide them with the websites that are appropriate. And of course, I'd love to give my email. If you have any questions about anything we talked about today, please feel free to give my email out. It's drkathydooley@gmail.com. It'll never change. So feel free to ask me any questions. I'd love to answer them.
We will certainly do that. And we appreciate you and appreciate all that you're doing. And we want to thank you, our listeners, for listening to the Principles of Performance podcast. Thank you for listening to the Principles of Performance podcast. If you've enjoyed our content, please like and share on your social media outlets, as well as subscribe and give us a review on YouTube, Apple Podcasts, or whatever your preferred platform is to listen to. For more information on the Principles of Program Design courses and workshops, visit us at www.principlesofprogramdesign.com and follow us on all of the social media channels where we post new content every day. To save 10% on any PPD courses, enter the discount code PRINCIPLESPODCAST10 at checkout. If you have any questions we can answer or suggestions for the show, you can email us at info@principlesofprogramdesign.com or message us on social media. Thank you again for your support.